My name is Chuck Slaughter, and I guess my 30-second bio is that 25 years ago, I worked in microfinance for a small organization called Trickle Up. I went back to school, got my master's in management at Yale, worked briefly as a management consultant, and then started a company called TravelSmith.
That's right.
It's a travel clothing company, which was a client of Wilson Sonsini. Thank you. I'm set alive. I was very fortunate that TravelSmith turned out to be the greater success, I think, than I imagined. I was able to sell it about 5 years ago. I think there was sort of, someone asked me this question: why, when, and how? It was sort of a convergence of three things: one, boredom; two, opportunity; but three, I think most importantly, a real desire to get back into the social space where I had started when I came out of college. For the last 5 years, I've been trying to figure out what to do with the rest of my life. I've done some work in private equity, but about 4 years ago, I got pulled into helping an organization that turned out to be the inspiration for Living Goods, which was attempting to apply the tools and power of franchising to the challenge of improving health for poor people in the developing world. And I worked for them for a couple of years as a donor, as a board member, and then as a pro bono CEO. And it was a storefront franchise using basically clinics and drug shops. And the question that came in getting involved in this organization was, how could you do what they were trying to do much bigger and potentially much more commercially viable, so you could reach a lot more people. The idea that sort of emerged was applying network marketing, direct selling model, Avon. What is Living Goods? So Living Goods is, as we like to call it, kind of the Avon of rural healthcare. We operate these Avon-like networks of women health entrepreneurs who do basic health education and who go door to door selling the cheapest, simplest, smartest solutions to the biggest killers of young children. Our goals really fundamentally are two. One is that we want to demonstrate that this model can have a significant effect on people's lives in terms of reducing their mortality and improving their economic life. And two, we want to show we can do this on a pay-for-itself basis within each country we operate. The reason for that is we start with the premise that the problems that we're all concerned about are very large, and the pool of philanthropic and government capital is not nearly large enough to solve the problems at the scale that they actually exist. Mm-hmm. And so the private sector, commercial models have to play a part. Are they the only solution? No. Are we a cure-all? No. But as we like to say, we'd like to be a cure-many or a cure-most. And we believe if we can address, let me take a step back. We focus on a short list of public health issues. So we don't cover all the bases. We don't do AIDS. We don't do chronic diseases. We focus on these 3 to 5 areas, which include malaria, diarrheal disease, nutritional deficiencies in young children, and healthy pregnancy, which collectively contribute to 60 to 70% of the deaths of under 5 children. And what's both tragic and hopeful about this situation is that these are all things, as many of you know, that can be treated or prevented at very low cost, extremely low cost. 20% of the under 5 deaths are from dehydration associated with diarrhea. This little packet, which costs about 15 cents, can prevent that death. Basically, it's Gatorade in a bag. So that's what we focus on, and the financial means to address these is within the means of most of the people that we're targeting. So not, there is a segment of the population who can't afford the 15 cents, and we have a solution for that too. We can talk about it, but the idea here is kind of the low-hanging fruit in public health. And if we can effectively reduce the mortality from these 3 or 4 causes on for 40 or 50% of the population, that's 40 or 50% of the population that the public sector, the philanthropic sector, does not have to attend to, and those monies can go to the harder, the tougher issues. Mm-hmm. So, one other, I think, helpful piece of background is that is around what the landscape is like where we work, so if if you live in a little community like 2 or 3 hours from a trading center in Uganda where we operate, it's not that you have no choices around healthcare. You have choices. It's just that they're not great choices. The misconception often is that proximity is a big problem. Mm-hmm. Proximity is a problem in some places, but it's the minority. If you live in one of these places, you can go to a public health center. The problem is the public health center is chronically out of stock. They don't got enough money. They're chronically undermanned. There are people who are on the payroll, but the payroll isn't always paid, and the people aren't carefully monitored. And so you can go, but I'd say your chances of getting quality service and having your product, what you need in stock, is about a 50-50 proposition in a lot of these places. Mm-hmm. Let's say if you get sick with malaria, let's hope you do it the first week of the month, just after the delivery of medicine got there. The private sector is an altogether different set of problems. So, private sector providers, clinics, drug shops, pharmacies, drug sellers, traditional healers, they're fairly ubiquitous. Hundreds of thousands of these in sub-Saharan Africa. There are 2 or 3 big problems, though. The biggest, in our view, is price. The prices are exorbitant. The study came out last year from the Lancet. It showed that in East Africa, the street price of the kinds of things that we sell here averaged around 350% of manufacturing costs. Now, in many retail systems, that's the kind of margin you need, but it is unacceptable, exorbitant tax on the poor. And of course, the farther you are from a central city, the more you're going to pay. And of course, the farther you are, probably the poorer you are. Mm-hmm. So there's a regressive pricing system. So prices are very high. The other problem, of course, is quality is low. The training of these independent, outlets is virtually non-existent. The monitoring is non-existent. And the quality control of the products is a serious problem. In East Africa, up to 50% of the products you see on this table, if you came into a small drug shop, would be counterfeit in one way or another. Either a simple counterfeit where they're just knocking off the brand name, but more likely ineffective, non-existent, diluted active ingredients.
In the drugstore?
In the drugstores, pharmacies, private drugstores, pharmacies. Rampant problem. So, what we're doing in essence, and the other condition here you have in the private sector is almost perfectly fragmented, almost perfectly atomized, almost perfectly inefficient. You have tens of thousands of. There's no CVS, Walgreens, Farmers, Boots. There's none of that. Certainly outside of the capital cities, and so it's no wonder the prices are so high. There's no buying power at the end of the rope, and there's this very Byzantine supply chain. Just layers and layers of sub-distributors, regional distributors, wholesalers, resellers. And so, from a business point of view, we actually believe that this is quite a stunning business opportunity. I mean, it's sort of a textbook business opportunity. Enormous need, financial ability, and this incredibly fragmented landscape. And what we're doing is applying a business model which has been enormously successful in the developed world. So franchising and direct selling. So if you look, in this country, franchising in one form or another, if you look at retail and restauranting, it's 30, 40, 50% of what's out there. And it works because it lowers the risks and increases the profits for everybody in the system, whether you're the franchisor, or the franchisee, or the financer. And so what we do really is we are aggregating the buying power of lots of small sellers. So we build buying power, we push it downstream, and we cut out links in the chain. And each one of those links has a transaction cost and a profit margin. We recapture that, we build the buying power. And as a result, today, even at our fairly modest scale, everything you see on this table averages 30% below prevailing retail. Some things as high as 50% below, while still providing a 20% margin for the end seller.
So Chuck, just to
Please, Nancy.
Celia.
Celia, excuse me, sorry.
Yeah. So do you control the price that the local door-to-door? Okay.
Yep.
They can't add on any.
Right, there's a maximum price. And if they violate the price, then you get one chance, second chance.
Right.
You're out. There's a lot more I can tell you. I want to sort of move more to the Q&A part and talk a little bit about what some of our needs are right now.
Mm-hmm.
We're still a very young organization. This is a very big challenge we're tackling, and we absolutely start with a premise that we're aiming for this very big prize in terms of a disruptive change in how the poor access health care. A. B. There's no way that living goods by its own little self is going to solve this problem. And so we need our real fundamental long-term strategy is demonstrating that this model can work on a commercial basis and encouraging other actors, principally in the commercial space, to come in and see the market opportunity of serving these markets and both these customer segments and delivering these kinds of products. We are one of the things that we're in the process of starting right now is looking for collaborators in the private sector who we can either joint venture with or who we can persuade to put down some money and take a swing at this. And so we're in discussions with Shackley, which is a big direct selling firm based here in the Bay Area that works in the nutrition space. We certainly would love to be in dialogue with people like Amway, Avon, and so forth, who all of them have multi-billion-dollar direct selling businesses. We also believe that the fast-moving consumer goods companies like the Unilevers and Procter & Gamble's, P&G is already a partner of ours, that there's an opportunity for them in this and what we're doing. The big consumer goods businesses, their growth is stalled in the developed world. Almost all their growth is in the developing world. But even there, Unilever is an interesting example. They're the market leader in their products in India, but they've saturated the middle class, and now they got to figure out how can we bring this to the other 400 million people in this country. So that's one of our main long-term objectives. It's high on my wish list right now are people who have connections and influence in kind of companies for whom success with this model would be a meaningful business opportunity. We are new and small and learning in almost everything we do, from perfecting our legal rights to our intellectual property, I was just talking a little about, to getting our communications game in order. I would say we really don't have a communications game right now, despite the fact that I spent most of my career in marketing. Our website, I will cop to, is a poor showing. Let's put it that way right now. So we're actually just in the process, I was explaining this to Julie before, of doing a 2.0 on the website. Not completely realized yet, so we would welcome input. We'd welcome any expertise people can bring to the table about that. Website is nothing if you don't get people to come see it. And so we need we really need to work on a marketing communication strategy. PR, we've done almost nothing. Somewhat, somewhat intentionally, I think we've kept the light under a basket because we wanted to be a little bit farther down the road in terms of proof of concept before we say, oh, hey, look at this, this is the greatest thing. And now I'd say particularly in the last 12 months, we're feeling more confident that we've got a story to tell. The financial metrics are looking stronger and stronger. The health impacts are looking better. Our M&E game is very robust right now. So I have a longer list, but why don't I shut up and ask if there are questions? I don't have good intelligence on that.
But it's a business, right? I mean, it's nice to be happy and you're not going to feel too expensive.
Yeah, I mean, it's not less this kind of thing they're knocking off than like, malaria medicine, antibiotics, the higher ticket items.
I'm just wondering about like connecting with them.
Yeah, it's kind of a racket. You pop one, it's another one is going to pop up.
Can't unite with the bad guy.
Diluting medicine and marking it up to them.
But if there's such a huge, I'm just thinking that.
Yeah, but there is. I will tell you, there's another. There's a. This isn't your question, but there's another strategy that we're going to test at some point. So there's basically kind of three flavors of franchising. What we call greenfield, which is like finding new agents to set up and build from scratch. Then there's conversion franchising. Like Ace Hardware is an example of conversion franchise, where you go out to existing sort of mom and pop shops, like these many private providers I talked about, who have poor buying power, who don't have good support, training, marketing, branding, and so forth, and say, we'll give you the benefit of our brand, our marketing spend, quality control, access to low cost, and you have to play by our rules, i.e. only buy quality stuff from us. And I actually think that's probably going to be an important strategy for us in the long term. We decided it wasn't the right place to start because there's a downside with conversion, which is that those existing outlets all have bad habits that you have to cure them on. So we want to get the model right with people who don't have that baggage.
You had a third
The third one is a fractional franchise, which is, you can imagine what that is. So instead of taking over a whole shop or clinic, you say, we're going to be this. There's a pretty successful fractional franchise in family planning called Green Star in Pakistan. And they go to a pharmacy and say, we're going to sell you our suite of training and products around family planning, and we'll offer you our brand for that. Yeah.
So what kind of cultural issues have you run across in terms of marketing to the people who are in fitness?
Nothing significant.
You've not had any issues in terms of explaining to people that maybe why these things are important or
So there's so from a cultural point of view, no. I mean, there are. If you talk to specific products, people have misconceptions like bed nets. People insecticide-treated nets. There's been rumors spread that the insecticide in the nets, is worse than the cure is worse than the disease. That sort of thing. Yeah. These two little flip charts you see here. You might take a look at one of those. There's behavior. We're in the business of changing behavior. So which there's always people. That's changing behaviors around health. It's hard to do, no matter what market you're looking at. Try to change behaviors in this country about how people eat and exercise and smoke and do those sorts of things. And it's the same version of the same human behavior issues that we're dealing with. Why do I have to give these nutrients to my kids? And, why is it important for me to see a doctor, when I'm only 3 months pregnant? My mother didn't. And so this is one of the educational tools that we use. And you'll see I think these are two different sets of topics in each of these books. And it has a visual on the front, and the backside has a discussion guide. And usually the discussion guide is getting to some of these underlying sort of blockages.
The community health workers coming, all literate?
Yes, then you have to, the worker has to obviously be literate and numerate.
And in the community that doesn't
Variable. That's why these are visual.
Yeah.
Yeah. And we have to assume the clients are not literate, for us to succeed. Please.
Back to the conversion engine.
Yeah.
Would that be a shift from the model, and that you would be franchising in a more storefront type place, or is that the conversion engine that you're doing to the graph or something else?
Yeah. That's a great question. It's a very good question. Almost certainly, in that case, we would be doing storefront. And we sort of come to belief in the long term that doing both will be good. I just didn't feel that storefront alone was a winning model in terms of scale. Or one challenge with storefront is they're more biased towards treatment than prevention. It's more the sick care than the health care kind of bias. But people still get sick, and they need a place they can depend on. One intermediate step we're taking right now is we are creating a network of existing preferred private providers who we vet. So when we need to refer someone for secondary care, there's someone who we have vetted. We're just testing that idea and sort of the step in that direction.
These storefronts, even in the preferred one, in your opinion, is it more of their main focus is the retail, we will sell you this product, or is it also that they do have the ability to actually diagnose and or treat, know what treatment to give?
They're pretty much in the vending business. It's mostly most of these are a little walk-up window, and I'd say 9 out of 10 conversations are, please sell me this. It's like, don't, and I've been in a lot of these where there's like, they're usually, you have to have a license to have one of these. You have to usually be a registered nurse or something, but it's rarely the person who got the license who's running it. The sister, the daughter. I've had 12-year-olds dispense me antibiotics. One other thing I'll mention, which there might be some interest or expertise in the SV2 world, is a very important opportunity for us is around mobile phones. And despite the part of the world that I live in, I've been a little bit of a Luddite about technology. But a couple things have really changed my mind about this in the last year. One obvious one, which is that we learned that we came to understand that probably 90% of our agents already have a mobile phone. You can buy a used phone in Uganda for about $10. Although airtime is frightfully expensive. It's actually paid more than 2 times per minute there than you do here. And probably 60 to 70% of the client households have them. That was realization 1. Realization 2 was when we're looking at the public health impact. We have a lot of shoe leather. We can get to knock on a lot of doors. But the key part of the public health impact comes from treating a case, an acute case, and a kid can die from malaria, within 24 to 40 hours of onset of symptoms. So if you don't get it treated quickly, you're out of the game. The only way you win that is by educating the mom and getting her to seek care quickly. And now there's a big obstacle if you're that mom, right? Right now, you got to decide. Think of malaria is an interesting case. Even in under 5s, the rate of mortality from people who get malaria is actually relatively low. So an average kid will get it 4 or 5 times a year. And the overall population rate of mortality is under 3% of incidence of malaria lead to a death. And yet it's so prevalent. That's why there's still the high absolute number of deaths. So you can imagine, 19 times out of 20, your kid is not going to die from malaria.
Mm-hmm.
He's going to get a bad fever. He's going to be miserable for 10 days and then work through it. And each time that happens, the mother's got to decide, do I have the time to waste a day to go to a health center or a clinic, lose productive labor, whatever, figure out what I'm going to do with my other 4 or 5 children. And so we got to lower the barriers, and the cell phone's a way to do that. And we have the agent who's got the stuff in her community. And what we've started a campaign this year is to call me for help. We've got the stuff, we got the agent, and we'll train the mom to see the symptoms and call the agent, have the agent come to her house to treat. So that's like the simplest, stupidest way to use the technology. We're also looking at using SMS. And before the end of the year, we'll be testing something along these lines. There's relatively cheap technology available right now where we can, one thing we're doing is we're registering pregnancies everywhere. So we're trying to, particularly young mothers, get them started with the right behaviors. So we got a nice combination to really make the cell phone powerful. We know the pregnant mother, we know her due date, we got an agent who can serve her. Now we can send her an SMS to do everything, remind her to do everything she's supposed to do. Take her prenatal vitamins, get her prophylaxis from malaria, schedule her antenatal visits, make her birth plan, and then after the baby's born, reminders around immunization, and so on and so forth. And then we can also send that same reminder to our community health promoter. So there's, go visit Jane. Sorry.
Just the numbers you quoted when you started talking about cell phones. I mean, it sounds like 10 minutes of time might be a week's wages for these people. How does that factor into it?
Yeah. We have one simple workaround for that, which is that they're all prepaid cards. You can ping without spending any money. So we're setting up we're going to set up sort of a Morse code, which is one ping is I need something, I just come pay my house a visit. And the double ping is I've got an emergency, I have a child in distress, come bring it. So that's zero cost to that. But we're also looking at ways. We're thinking about giving a mom, as a incentive, giving her an airtime card, when the baby is born. So if there's a baby kid's in distress in the first 30 days, 20% of under 5 deaths in the first 30 days. We actually, it's a very good point. One of the things we're looking at is cutting a deal with one of the local cell companies and saying, cut us a break for our own purposes on airtime, and we will be an exclusive distributor for you, that sort of thing.
That's part of this is
Yeah.
organization. And traditionally, we've had several categories of things we potentially can help the organization on. One is, it sounds like your business plan is pretty good shape right now. Another is board. Maybe occasionally we'll have people bring board and we can add a lot of value there.
Yeah.
Some is in the HR area. We've got a lot of HR professionals who can assist with help. Going on legal, we'd be interested in helping on IT.
Yeah.
The website, if you need terms of use, providers, and things like that. Where are you from an organizational perspective? And do you see using those kind of, not your major business, but these kind of value add specialty areas that potentially you can help you?
So board development has been high on our list. I'm happy to share the news, though. Since the last time we spoke with you guys, we've actually elected 2 new board members. I think the big win for us is, my firm belief is the big win is bringing the private sector into this. And I think, it's great for them to have the story that there's a public health benefit. I think that's compelling. I think there's a business rationale for it, and it's good CSR. But we really want, in the end, we'd rather appeal to their P&L than to their conscience.
You want it to be sustainable over time.
Yeah.
Well, that's what they're driving for anyway with a lot of the CSR stuff.
I think it's also the microenterprise aspect, because that's a really hot field.
That's true.
These people start their own businesses and make their own living, do whatever is very core.
Yeah.
Remind me again, how do they finance the purchases?
this stuff.
Yeah. How does it model?
It's pretty simple. There's two forms of assets they get. There's the fixed assets, quote unquote, which are things like the bag, uniform, a storage locker, and some these flip charts, which aren't cheap.
Mm-hmm.
All that we give them on loan. So we lend to them, I should say. We retain ownership of it, but they are given the right to use it as long as they are an agent in good standing. That lowers the barrier to entry financially for them. It also enables us to control the brand.
Mm-hmm.
So that if we have to kick somebody out, which we do, that we can repossess those things without there being any ownership title issues to it. Then the products, they get a loan, a microloan, traditional sort of microfinance bank from us, usually below market also, and a longer than average payback period. So that's $50 to $100 loan typically, and they get it in the form of the product.
Right.
But then it's $100, pay us back, $2 a week for 50 weeks.
Mm-hmm.
Do you have a microfinance lender, or are you doing it yourself?
Yeah, so many of you may know we operate in two modes there, right? And so when we originally started, the theory, one of the original sort of premise and strategies was, look, if we want this to be sustainable, it would help to leverage existing assets of some kind or another, distribution, microfinance, something. And so we went into Uganda. We ended up doing a partnership with this terrific microfinance group called BRAC, which is one of the original microfinance organizations from Bangladesh from the 1970s that are now, I have to do short hands. How many of you, before you heard of Living Goods, had ever heard of BRAC?
Mm-hmm.
I don't know if there was a perfect source of information, but it's the largest NGO in the world.
Oh, wow.
100,000 employees. 6 million microfinance borrowers in Bangladesh, 14-country footprint. It's the greatest success story in development that nobody knows
Was
about.
it originally called awareness program?
They
No,
need some
it was called
pro bono
BRAC.
PR.
Yeah.
They do.
Yeah.
It was just recently released, Freedom from Want.
It's a bit of history of BRAC. It's a great read.
That may be something.
Yeah, yeah.
To the poor, they have some other version.
Fazal Abed, who's the founder, was just received a knighthood last year. So we started as a joint venture with them, with BRAC essentially as the implementing partner. And they, in addition to being a powerful and successful microfinance entity, they also have 30 years experience in public health. So it's really a perfect partner, including doing a version of sort of volunteer community health workers. As we often say, that what happened with this partnership is that it's great. What was great about it was the potential for scale. It was this enormous global footprint, and the size of the organization is a great, potential asset. The size of the organization is also the biggest problem. Because they're big, they're set in their ways, a little bit slow-footed, and so forth. And the success of the implementation with BRAC was very up and down. So a year ago, we launched basically if you're thinking franchising terms, it was sort of versus a master franchise versus a company-owned franchise. So we started our own owned and operated division network, and it was the right thing to do. We did it partly as a hedge against the risk in this relationship, and partly as sort of a learning lab. And it's been a big success on both fronts. So we're the directly operated network, while smaller, has much higher productivity per agent, both in financial and health metrics. And it turned out, actually, the beautiful piece of the story is it turned out to be actually the best thing we could have done for the relationship with BRAC, because much more persuasive to show somebody how to do it than to tell them how to do it. My ninth grade English teacher often reminded me. And so the success of actually doing it differently, has really helped that partnership. We just signed a new 2-year agreement.
Oh, good.
Yeah.
I have a question.
Please.
So you're wanting to move toward this being a successful self-sustaining business.
Yeah.
So what part will fundraising play in your finances as you go further and further down this path? I mean,
Yeah.
do you envision a time when you just won't be doing any fundraising, or will it always be that you'll need
Yeah.
that to start in the next country, or how will that work?
For the foreseeable future, we're going to be in the fundraising business because we're growing.
Mm-hmm.
You know, so growth requires capital,
Mhm.
and and you know, I'd say if I'm looking at a 3 to 5 year time horizon, we're going to probably be just be in 2 countries: Uganda, where we are now, and Kenya. We're not going to do, you know, a common NGO thing, which is decide that the more countries you have, the better.
Mm-hmm.
You know, we only go to countries we think we can be big.
Mm-hmm.
You know, a minimum of service area of 3 or 4 million.
Mm-hmm.
The second country, I think it's an 80% likelihood that we'll create that as an NGO,
Mm-hmm.
but with the hope that it reaches sustainability on a faster timescale. But we still think it's probably a minimum of 5 to 6 years from a dead start to break even.
Mm-hmm.
And so that will most likely be grant funded.
Mm-hmm.
Third country, my bias right now is to make a third country do that as a corporation, and hopefully we'll have enough experience and confidence around the business model by then.
Mm-hmm.
And then I think it'll be important. It'll be an important demonstration.
Mm-hmm.
And so we'll probably for that we'll look for, you know, probably kind of soft private capital, you know, but
Cool.
you know, sort of SOCAP kind of money.
Mm-hmm.
2 questions. What is your penetration in Uganda now? And I don't know if you measure it in terms of
Yeah.
And when you do enter a community, do you start in certain places and then scale from there, or how do you?
How does that work?
Yeah, scale.
So the first question is pretty simple. We have approximately 600 agents right now. Each serve, you know, 700 to 1,000 people. So we're reaching about 500,000 in Uganda at the moment, service area. We've made it. Population is about 30 million. But we made a deliberate decision this year to stop at that scale for a period of 18 to 24 months. So the 100% of our calories can go towards improving the financial productivity, unit productivity, and demonstrating the health impacts. You know, growth consumes a lot of the oxygen in the room.
Mm-hmm.
I'm sure as you all have been in startups know. And so we're pausing growth to improve impact and sustainability. And then when we're more confident about that, we'll go into growth mode again. In Uganda, there's a little bit of a question mark about how we will expand. It's going to be somewhat of a function of where the partnership with BRAC goes after this next 2-year period. We are planning to launch Kenya before the end of next year. Let's get started, incorporated, and start recruiting there. Geographically, it works pretty simply. We pick target communities. We go in and we set up a little mini branch, a little mini warehouse. And that branch serves approximately 30 to 40 of these agents right now. Again, each with service area, say called, for simply say, about 1,000. And the goal is for the notion is that these agents can walk to the branch to get resupplied. So, one thing we're going to be experimenting with in the next year is potentially increasing the number of agents per branch. It's a big strategic question. And more specifically, potentially applying a second level to the system. So I don't think we're ever going to do the multi-level sort of thing in the Herbalife sense, but allowing each agent to recruit one apprentice or downline, as they say in the direct selling world. And so we're trying to figure out a way to do that where the downline costs much less for us to support, but that has maybe 70 or 80% of the efficacy of the upline. And so can we experience in the mobile phone world? We have found a couple of small companies and organizations who've developed mobile phone applications specifically for developing world economies, even specifically for the health sector. this one that some of you may have heard called Voxiva. There's a guy here, I think you guys may have even spoken to, Josh Nesbitt.
Yeah.
Right. So Josh, we're probably going to hire Josh to do this for us.
Okay, good, because I was thinking, why couldn't you partner with other?
No. Josh is probably going to
Yeah.
build the technology for us.
Good.
Yeah.
That makes sense.
I mean, actually, he has it.
Right.
He's going to help,
Proliferate.
help us apply it.
Yeah.
So he's awesome. We're very excited about
Yeah. Oh, that's great. I'm glad that you're doing that.
Yeah.
Makes sense.
that. SMS.
Yeah.
It's a perfect fit on the issue, which is out of time.
Yes. Yeah. I am going to can I throw out another something we're looking for?
Yeah, we've got 10 minutes left.
I'm a graphic designer, just for marketing, and with a lot of these things, I often a little bit go back and forth between whether we want to get pro bono or paid, or maybe somewhere in between, discounted.
You're thinking of a contractor, though, right?
Yeah, contractor,
Not
not staff.
staff.
Yeah, contractor.
Good.
So.
I have a lot of names on that.
All right. You know how to find me. Somebody who would, obviously we'd love somebody who'd be psyched about this and who would connect with it.
Absolutely.
Yeah.
When I think back to, I think it's corruption, like with all the foreign aid they receive and all the NGOs and all the natural resources, I mean, that's why they're not doing better. Do you face that? I mean, is that...
Corruption's a big issue. We do. We have come nose to nose with it, mostly at the local level. At the point of little local councils and petty bureaucrats, and so it's been it's never stopped us, but it's sucked energy away from time because you have little local bureaucrats who can stop you, and we have a no backsheesh policy, but you have to be creative sometimes on how you deal with these guys.
It's also helpful for us to think about it from the perspective even of that petty bureaucrat who's clearly making the wrong decision right into asking for a bribe. At the same time, they see development professionals drive by and air conditioning NGOs all the time, air conditioning SUVs all the time, and an extra $5 to us makes them something. It's their culture too. I wouldn't say it's their culture. I wouldn't say the corruption is culture. I'm not nurses studies, but I wouldn't say it's their culture, but there's a vast difference, and they see it as international development professionals coming in to help, but they've already, as we come in, already have far more resources. This is another perspective.
Yeah, I mean, this guy Steve, the UNICEF guy we brought on, that's just kind of his philosophy. He doesn't view it as he takes a more sort of anthropological view of it. It's not necessarily people who are bad actors. They're just getting along. They're getting along.
I'm not saying corruption's right. I don't want
to.
Yes, you are. Wow. Any other questions?
Great work.
Thank you.
Great. Well, let's wrap up so that people who want to talk one-on-one with Chuck about some of the stuff he's brought up can do so. So thank you so much, Chuck.
Thank you.